So welcome back to the TRT and Hormone Optimization YouTube channel. And back with us is advanced clinical practitioner Felix from the Eden Clinic for Men. Welcome back, Felix.
Thank you very much, Dr. Devils. Thanks for having me back.
It's a pleasure. So let's start the 21 rapid fire questions I have for you. They are very basic, but they are for newbie TRT users that want a lot of information in a minimum amount of time. So let's start off. So what are the benefits of TRT?
Well, I mean, if you're truly deficient, you have low testosterone, then the benefits are going to be numerous, because it's not often that you have low testosterone levels and don't have a number of symptoms. The most common ones being fatigue is a big one, lack of recovery from exercise, sometimes anhedonia, that sort of low mood or loss of sense of self. And then, of course, you've got some of the more sexual problems that people sometimes describe, like erectile dysfunction, lack of libido. Although that last one, I think, is quite a complex one, and it's not solely to do with testosterone levels, but it certainly is a contributing factor. So if you're truly deficient, then the benefits would be the reversal of all the negative symptoms associated with your low levels.
Yeah, right. And what are the risks or side effects of TRT?
Yeah, so these vary a bit, don't they, between individuals? You'll get some people that absolutely, sail on TRT and they have absolutely no issues whatsoever. But the long and short of it is that if you're having negative side effects from your treatment, the protocol is not being done correctly, and the risks, when done properly, are very minimal. Because we're talking about replacing deficient levels here. We're not talking about supplementing already healthy levels to supraphysiological territory. I think it's when you get to that sort of level where your levels are too high that you start to see some other negative side effects, such as you can get skin issues, such as acne, that can be contributed to by sort of higher levels of testosterone, or an imbalance between all of your hormones, not just the fact that your testosterone's high. And then, that's about it, really. Like, if you're on injectable therapy, I guess, if you're not very good at aseptic non-touch technique, you might get a risk of injection site infection. But yeah, if you do it right and you're being monitored by an objective, well-trained healthcare professional, the risks are minimal.
Mm-hmm. Third question, is TRT for life?
This is an interesting one, isn't it? You get a lot of it. This is a bit of like this side or that side. So I would say no. You get a lot of people that say, oh, if you're truly deficient, why would you start TRT, have alleviation of your negative symptoms, and then come off it? Now, and the answer to that one isn't simple, but for some people, yes, they do have clinically low levels. They have either primary, secondary, or tertiary hypogonadism. They go on TRT, they feel some benefits, but they feel like they never quite get to where they were expecting to get to in terms of alleviation of their symptoms. And for some, they might decide that that's not in their best interest, and it's actually, easier to deal with the low level symptoms that they had prior, rather than, having to inject or do other sort of protocols for the rest of their life. And that's entirely down to the individual. So I think, it could be yes and no, the answer to that question. But for me, it depends on the patient.
How many times per week do I have to inject?
Oh, this is a big debate, isn't it? I think, to start with, I think it's worth saying that most providers will agree that once every week or once every 2 weeks is just a ridiculous protocol. There's a threshold for when it's too low in terms of injection frequency. But for me personally, the answer is probably whatever is going to work for you as the patient. And for me personally, I'll work with them to find the injection frequency protocol, if they're doing injections, that is the one that they will keep up the most, the one that they don't forget. And now you'll get some people that say this protocol is better than that protocol, that one's better than this one. You've got the the die-hard daily subcutaneous injection crew, and then you've got the die-hard intramuscular crew. And you do get the odd patient that has been on TRT for years and they inject just once a week and they're fine. But for me, I think 3 times a week is a good middle ground between those, and I think doing that in shallow intramuscular injection is probably my preference, and where I've seen most guys find a good balance between not having to inject all the time, but having good alleviation of their symptoms, and having to not have to break their skin every day. Like it's whatever works for you best as the patient and what you will keep up with.
Mm-hmm. You know, in some Scandinavian countries, I've had a lot of comments from people from Sweden or Norway, whatever. They only have androgel or libido. So, and they get
libido.
1 gram of testosterone libido
Yeah.
for 12 weeks. So,
yeah, so we can't talk about injection frequency without mentioning the libido, can we? So I actually like libido, but not once every 12 weeks. So I think there are other ways to use that ester, and that one's testosterone undecanoate. Like it's actually very good, but it's just you need to adapt the frequency, and I think injecting libido in smaller doses more frequently can actually work, especially for guys that you've tried everything else on and it's just not working. Like going sort of up to like once weekly with sort of 100 to 125 milligrams of libido, I've seen work wonders for people that you thought you couldn't get stable on any other protocol. So like I said, it's different for each patient, but there's definitely things that can be done, and the manufacturer guidance isn't always the best in real practice.
Yeah, sure. What is the best TRT dose?
Oh, wow, this is even more than the last one, isn't it? So there isn't one really that you can say this is the best TRT dose, because again, this sounds like I'm repeating myself, but it is very patient specific. You've got a threshold, haven't you, where you're as a provider, you're not going to go, okay, we'll go with the dose that alleviates all your negative symptoms, and then a guy comes back to you and goes, well, that's 500 milligrams a week. Like you're not as a provider of TRT going to be endorsing or advocating that kind of thing, because there is pharmacologically and physiologically going to be nobody that has that level of, for example, there's an enzyme that moderates the cleavage of testosterone esters that are injectable, called phosphodiesterase type 7B, and that's what's responsible. If you have a lot of that, then you'll cleave things very easily. You'll get rid of that ester very quickly and metabolize your testosterone faster. If you have very little of that, you'll do it slower. But I think there's a threshold at which you wouldn't require 300, 400, 500 milligrams of testosterone. So I think the answer is that whatever dose works for you, and that's found through working with your provider over time. It's not something that we can just hit spot on in the first couple of months. Generally speaking, you're working with guys for up to a year to get them stable and finding that sort of sweet spot, and then it's dependent on all their other lifestyle choices as well, like, which sort of isn't part of this question, but really does impact the dose.
Yeah. What if someone don't likes to inject, hates needles maybe? Are there any other good options?
Yeah. I mean, I don't know anybody that likes needles, but jokes aside, yes, there's some other good options, like ones that there are topical, there are implantable. You've got pellets, not used really at all in the UK where I work, but you will find private providers that do provide access to them. I don't like pellets purely because sustained release in a sort of subcutaneous or shallow IM implantable device is just too unpredictable for me. Like you've got a certain amount that is going to be absorbed over time, and if anything happens to that, then that could cause it to be faulty, and you could release more, you could release less. You may not absorb well via that route. So then you've got transdermal, like patches. And then you've got the ones to avoid, obviously, topically, are any of the unbound gels. So Testagel, Tostran, they're just not good options for people that don't want to inject, because they cause more trouble than they actually solve. They peak your levels very quickly, they go down very quickly, which means they require multiple applications, and they are often alcohol based, like, so they cause skin irritation, so you have to rotate sites. Then you have to think about where you're doing that so you don't transfer onto children or partners. They're ones to avoid. But I think if you're going to go the non-injectable route, my recommendation would be polymer based creams transcrotally, because there's very little work required to make sure that that works. I mean, you've got the occasional guys that don't absorb well via any transdermal routes, including scrotal application, but that's the exception rather than the norm. So yeah, I think polymer-based transscrotal creams are very effective for people who have needle phobia.
Yeah. Going back to injections, what is the best place to inject testosterone?
Yeah, so it depends on what route or what type of injection you're doing, I guess. So if you're one of the people that gets on very well with subcutaneous injections, then anywhere where you can pinch an inch of fat and use a small gauge short needle to so that a lot of people commonly do the side of the hips or the subcutaneous belly fat at the lateral edges. And then if you're injecting via shallow intramuscular or intramuscular, then yeah, I'm a big fan of the ventrolateral glute, like so, because there's very few major nerves that you could interrupt there, even with a larger needle. But yeah, it's a almost painless injection there if you're using a slim pin, for example. Then you see people that will, I don't often advocate delts, but it's a perfectly acceptable muscle to utilize, and it's easily accessible as well. You can rotate either side. So yeah, but I'm a big fan of ventrolateral glute.
Mm-hmm. What is the best needle to inject the TRT?
Yeah, again, if you're going, to be honest, actually, it doesn't really matter about subcutaneous versus shallow intramuscular, because unless you're exceptionally overweight, then a 27 gauge to 29 gauge half-inch insulin syringe is my hands-down recommendation for most people.
All right. Are SubQ injections as good as intramuscular?
See, this is a tricky one, isn't it? So there's evidence of efficacy for both in the scientific literature. However, it depends what your priorities are and how that affects you in terms of your alleviation of your symptoms. So what they see in the literature is that when you do subcutaneous injections, because of the lack of vascular bed, so lack of blood supply, this is relative to a muscle, then you get slower absorption. You also get some absorption through the lymphatic system in fatty tissue. But in theory, in your head, it makes sense doing it like that because it sort of gives you this idea that you've got a slow, sustainable sort of absorption, and that should lead to more stable levels. And the theory and physiology adds up with that. But if that doesn't alleviate your symptoms the way you'd like them to, and you're finding that you'd have to use larger and larger volumes because the dose is higher for subcutaneous, you're then going to be risking sort of having deposits of oil that don't get absorbed. You can start getting more pain, or you get lipodystrophy, where you get buildup of fatty sort of nodules in that area, and that can be troublesome. So yeah, whichever one works for you. I'm a big fan of both because I've seen both work very well for people. Shallow intramuscular, I think, in my experience, tends to give guys a sort of better initial peak, and that makes sense because it's there's more blood supply, so they get a bit of a quicker rise in serum concentration levels. But over time, I think you see some people get more stable and sustain that stability over time with subcutaneous. But then again, you see guys that are on years intramuscular. So I think whatever works best for you. I don't think there's one that's better than the other. It's whatever is going to keep the patient feeling their best and being healthy.
Mm-hmm. After starting TRT, when do I have to have my first blood control?
Yeah, so I guess that's dependent on what you're using as well. So if you're injecting TRT, then we're going to be thinking that this is bound in an ester of some kind. So that'll dictate largely when you might be better off doing blood tests, because you don't ever want a blood test to not yield usable information. It's because you want it to change your management. Investigations change clinical management. So doing a blood test at an incorrect interval that doesn't give you information to use is not good practice. So if you're using, for example, a medium chain ester like cypionate or enanthate, so anywhere from 5 to 10 days in the literature, it tells you the half-life is for those. Take your pick from that. You then apply the basic pharmacological principles of 5 times the half-life, and you calculate it from there. So usually I would check someone between sort of 5 and 6 weeks after starting a medium chain ester like cypionate, or enanthate. But yeah, if you're using other forms, like so if you're having cream, then that changes things a little bit as well.
All right. What's the best moment to have this blood control done?
Yeah,
Drop or peak, I guess.
Yeah. So again, depends on what you're doing. If you're injecting, then we would really want to be checking you in a trough. So just before your next injection. So we want to see what your test levels are like at their lowest. So yeah, it's something that again is slightly dependent on the ester, but most of the time in injectable therapy, you're going to be checking in a trough. If you're utilizing topical creams, transmucosal creams, for example, it's slightly different because we want to check that you're actually absorbing it well. So because like I said earlier, some guys just don't, and if they're having trouble with their symptoms not being alleviated, and then you'd want to check, say they'd apply it in the morning, and typically you'd check their bloods in the afternoon and just check what their levels are like in terms of absorption.
Yeah. What is the best time of day to inject?
Yeah, so logically your lizard brain, your logic brain says the morning, doesn't it? Because we know that in a healthy functioning HPG axis that we have a diurnal rhythm to testosterone synthesis. So we have a spike in the morning, and then we have little sort of peaks and troughs throughout the day, and then it tails off towards the evening. So yeah, logically your brain tells you you should inject in the morning. But again, I think this is patient dependent. If you're someone who's got a very busy morning routine and you're likely to forget, then do it in the evening before you go to bed, because everybody goes to bed at some point. So if you take that injection at whichever time of day is the time of day you're going to remember to do it on injection day.
Right. What if my hematocrit is getting high? Do I have to donate blood?
No is the simple answer to that. So there's a great paper that a good friend of mine, actually, you've interviewed him before, Andrew Winge, has broken down, and it's titled "The Reevaluation of Hematocrit as a Determinant of Thrombotic Risk." And if anybody's not read that paper, it's very clear cut that there is no causal relationship between elevated hematocrit and elevated red blood cell count and deleterious cardiovascular outcomes. You'd have to have sort of stage 2 and above hypertension, which would not be caused by a normal TRT dose. If you're getting stuff like that, you are genetically predisposed, you have other lifestyle factors, or you are abusing steroids like that, because that's what will cause those kinds of things to happen, to cause you to have hypertension. But yeah, on TRT, you don't need to. You will get a mild elevation. Everybody does, but it's not going to cause hypertension. So you can just relax, and it will settle. The numbers may remain slightly elevated, but you will feel fine, and you won't be at increased risk, according to the evidence.
A question I see repeatedly under many videos on our channel. Do I have to take anything else on TRT? Vitamin D, DHEA, pregnenolone, magnesium? Even today I wrote a comment, don't I have to take tadalafil 5 milligrams every day? If that is the case, who will tell me how much and when to start?
Yeah, I mean, this is the simple answer is no, you don't have to take anything else on TRT. If you've got a great lifestyle, balanced diet, you're exercising regularly, you're getting outside, getting some sun, especially if you live in a sunny country, doesn't apply to where I live. Yeah, so your vitamin D is up, then you don't really have to take anything else. It's something that if you're testing levels of certain other steroids or neurosteroids and they're low, then it's up to you if you want to supplement them, but only supplement them if they're A, low, and B, giving you clinical symptoms. If they're low and you just know they're low because of a blood test, but you have no negative symptoms, then there's not really any point unless they're going to cause you harm in the long run by being deficient. So yeah, you don't have, the simple answer is you don't have to, but there are certain circumstances where things like tadalafil can be very beneficial in terms of improving your longevity. So tadalafil, just as an example, improves the endothelial lining of your major blood vessels. So that decreases the likelihood of turbulent blood flow and the buildup of broken down tissue inside your vessels that might risk thrombotic events. So, if it's something that has a low risk profile and has added benefits in terms of erectile function, but also cardiovascular health. So yeah, it's something that is definitely something I offer to people, but it's not something you have to do.
I guess a lot of men optimizing their hormones are also interested in doing everything they can to support their health and longevity.
Yeah.
So,
yeah, I mean, that's it. Yeah. You know, DHEA is another one like that's proven to have positive health benefits. So yeah, if you're deficient in that, and there may be some mild suppression of that type of that part of the axis when you're on TRT, then yeah, by all means. But if it's not adding any benefit, then you don't, you know, as fewer medicines as you can take, the better, really.
really. What if my estrogen is high?
So, so what? Yeah. So you know, it all has to be relative, doesn't it? So, what is a high estrogen? Because what these reference ranges that they use are not for guys on TRT. They're for people that have a functioning HPG axis. So it doesn't apply to what the context is of testosterone replacement therapy. Now, there's a reason why people get worried about this, and like most things, it's got a tiny bit of truth to it. So the people logically think that you should worry about elevated 17 beta estradiol specifically, purely because of its relationship with how we regulate renal free water in the body via the kidneys. So it alters the set point of something called arginine vasopressin, which is a hormone that is directly responsible for interacting with aldosterone, renin, atrial natriuretic peptide, and they're all responsible for regulating our water through the body. So people put two and two together in the context of TRT and think if your estrogen's high, that's going to raise your blood pressure. The simplest thing is, if your estrogen's high and you just happen to have measured that, and you know you don't really need to, but if you've measured that and you see it's high and your blood pressure is normal, then everything's fine. Like it's not. You'd have to have a predisposing cardiovascular issue for your serum estradiol to raise your blood pressure, and it would be that needs addressing, not your estradiol, like, because that's just a correlative finding, and it's not an endocrine hormone specifically, so measuring serum levels is next to useless. You need to go on symptoms and other markers like vital signs. Like if you are having tachycardia or hypertension, look at all the other things that cause that. Don't go straight to estradiol because it's unlikely to be the cause.
Will TRT make me infertile? I guess a lot of young men worry about that.
Yeah. So yeah, the short answer is yes, it will affect your fertility if you go on testosterone monotherapy. So it will suppress your HPG axis, which, let's face it, if you're on TRT, was not working well in the first place. So you are supplementing testosterone because you had negative symptoms, and yeah, that will have also been fertility as well if you'd actually had that measured. Not a lot of guys do, but yes, it will shut down that link between your brain and your testicles, which we call the hypothalamic pituitary gonadal axis, or HPG axis. It will shut that down, and but it's not 100%. I've seen people, on relatively high doses of TRT, and you even read stories about it of bodybuilders and things that still manage to get their partners pregnant. So it does affect fertility directly. We do know that, and there are other medications you can have alongside TRT that can try and mitigate for that. But I don't tend to advocate that, because if you're thinking about fertility, then there's a whole other route of treatment we can go down to help you with that on TRT. You don't really need to worry about it. That's not to say that your axis is guaranteed to restart, but there's a lot of medication protocols out there that we can use with guys to help them conceive.
Another worry, will TRT increase the risk of getting prostate cancer?
No. So that's the short answer to that one. Again, the scientific literature is abundant on this. It was debunked many years ago. No, it won't.
Okay. Is TRT bad for the heart?
TRT is good for the heart. That's so it's the exact opposite. So there was this thought that this goes back to hematocrit, doesn't it? And estradiol. Like, there was this thought that those two things contributed to hypertension, which increases the likelihood of having strokes or heart attacks. But then there was massive studies done with hundreds of thousands of men that looked at all-cause cardiovascular mortality rates and low testosterone levels, and that found those rates to be higher. So you were more likely to have a cardiovascular negative outcome if your levels were low. So healthy testosterone levels actually decreased the likelihood of having a heart attack.
Good news then.
Yeah.
Will TRT make me go bald faster?
Yeah. So the short answer is yes and no. So if you have a genetic polymorphism for male pattern baldness or hair loss, then it may accelerate it a little bit because you get slightly increased DHT levels, and that contributes to follicle micronization, which will maybe cause you to shed a little bit faster than you were already destined to in the first place. But if you don't have that polymorphism genetically, then no, it won't make you go bald.
Right. Will TRT solve my sex drive and erection problems?
Yeah, we kind of alluded to this earlier, didn't we? Maybe not is the quick answer. So it's very complicated. So if your sole reason for your low libido and your erectile dysfunction was that your testosterone was low, then yes, it will help. And even if it's not, it will definitely help with your erectile function and your libido. But libido in particular is ridiculously complicated. It's so multifactorial. Just upping the dose of testosterone will not increase your libido. You have to have the right psychology, you have to have the right life circumstances, the right partner. So yeah, it's probably not gonna solve them, but it will definitely contribute towards them getting better. But that takes a lot of other work and looking at other factors.
Awesome. Last one. Will TRT help me lose fat and build muscle?
Yeah, this is important for the younger guys, isn't it? Like, it seems to be a priority. The short answer is it can, but what it won't do is do the work for you. Like, so if you eat like trash and you don't lift weights, you are not going to lose fat and you're not going to build muscle, regardless of how healthy your testosterone levels are. So if you align healthy testosterone levels with a good lifestyle and good exercise regime and good nutrition, then yes, it will contribute to those. And the short sort of science answer to that is that it increases the synthesis of something called HSL, which is hormone sensitive lipase. And that's part of a cascade response to lipolysis, which is the breakdown of fat. So yeah, if you've got low levels of testosterone, you have lower HSL levels, you're going to find it more difficult to break down fat. So healthy levels will increase the likelihood of lipolysis being efficient, but you have to eat well, train hard. That's it.
Okay, thank you so much, Felix. Before we close up, since you moved clinics, maybe tell the viewers how they can reach you if they want to get in contact.
No problem. Yeah, so I'm now working with Dr. Angela Service at the Eden Clinic for Men, which is based in Plymouth. But you can book on our website at edenclinic.co.uk, and you'll see that I'm bookable there, so you can book slots with me, and you can book slots with Angela also. So yeah, head over to the website edenclinic.co.uk, and you will find all of the details there.
The links will be in the description. Thank you so much, Felix, for your time. And see you in the next one.
See you next time.
Bye.